Okay, today we start with a new series been called HIV and PMTCT, meaning perinatal mother-to-child transmission of the HIV virus. And I'm Anna Nolte. I'm going to present this series, and there's going to be 3 lessons in this series. In the first lesson, which is this lesson, we are just going to discuss the general aspects of HIV and do a little bit of revision about general HIV aspects, but specifically what's very important for us to remember during labor, pregnancy, and specifically also the breastfeeding time. Then the next lesson is going to be specifically about pregnancy and labor, and then lesson 3 is about breastfeeding and the newborn. Now, these lessons are being focused to a large extent on HIV in private hospitals and not so much in public hospitals, where the management of HIV and PMTC is a little bit different. And it's just in general about the general principles of dealing with HIV during childbirth. So as I've said, this lesson will then be on general aspects of HIV in general, a little bit of revision where it comes from, and also a little bit about testing for diagnosis of HIV during pregnancy. Now, just a look at statistics, the maternal mortality numbers during 2017 and 2019. If we look at the 2 columns here in the beginning, and this column you can see are the biggest causes of maternal deaths during this period, and this one by far the biggest. Now, NPRI stands for non-pregnancy related infections, and HIV is basically the most important non-pregnancy related infection here. And you can see here the dark blue is for this period of 2017 to 2019. The highest or the most important reason for maternal deaths during this period. Then second highest is hypertension, and third highest is obstetric hemorrhages, which are antepartum and postpartum hemorrhage. Okay, on this slide, we are just going to talk in general about HIV infection, where it comes from and what it does. Now, HIV viruses get into the body in certain ways, which we will come to just now. And as soon as the HIV virus is into the body, it goes to certain cells, and we will talk about the certain cells just now, and it integrates then its viral genetic makeup into the genetic makeup of the cell. So it literally takes over the cell, and eventually the cell has now the viral genetic makeup of a HIV virus. The cell that has been invaded is now so abnormal that it cannot do its functions properly anymore. And at the same time, the cell, the so-called new cell with the genetic makeup of the HIV virus will now replicate and produce more viruses that will obviously invade more cells, and in such way the disease is progressing. Now, we've said that certain cells are being invaded, and usually these cells that's being invaded, this destructive effect, are usually on cells that provide and regulate immunity in the body, and specifically the CD4 T lymphocytes, or the helper T cells. They normally plays a key role in organizing the body's immune system and immune functions. Now, when the HIV virus invades these body cells, the CD4 lymphocytes decrease, they can't do their function anymore, and then, as we've said previously, the HIV viruses then increases. So the immune response in the body in total declines. And opportunistic infections, other infections, can then overwhelm the HIV positive person, because, as we're saying, the immune system doesn't do its proper work anymore. Now, in a normal body, under normal circumstances, a normal CD4 count is about more than 500 cells per square millimeter, while if there's less than 200, if the CD4 count is less than 200 cells per square millimeter, then we get it's ideal for the development of opportunistic infections. It's general knowledge on how the virus is being transmitted from one person to another. I think all of us by now know it. Just again, a little bit revision. We get the transmission happens because of unprotected sexual intercourse. That's what we call horizontal transmission. Then we also have transmission from the mother to a fetus or a newborn infant with breastfeeding, and that we usually call vertical transmission. It's also by using syringes and needles and blades that have been soiled by the HIV-infected blood, or an accidental needle stick injury that healthcare workers are very prone to, and then also a blood transfusion with HIV-infected blood. Also, fairly general knowledge is how do a person become infected during sexual intercourse? Now, the infection, the HIV virus is usually being spread by body fluids. There's a lot of these viruses present in different body fluids. And then they are being transmitted during sexual intercourse because there's a lot of HIV viruses present in vaginal discharge and cervical secretions, and there's also a lot of them present in semen, and then also in blood when there are small injuries or breaks in skin or breaks in the mucous membrane. Women are much more prone to develop HIV infections than men, and the reason for that is that the semen is being deposited in the vagina and in the fornixes of the vagina, and that makes that the semen stays there for quite a while, and that makes that women get the infection much more readily than men. The question is also being asked if whether HIV is very infectious, and in general, and in comparison with other viral illnesses such as hepatitis B and the other hepatitises, HIV is not very infectious, but repeated exposure to a large amount of the virus is usually needed for transmission. So repeated sexual intercourse, for example, will cause that the woman eventually, or the man, but in our case, we're specifically focusing now on women, will eventually get the HIV virus. And this is very important for us during pregnancy, labor, and breastfeeding, and we will come many more times back to it. People, and specifically women, again, with early infection, and we will get to advanced infections, are more infectious. So women who are getting HIV positive during pregnancy and during breastfeeding are more infectious than women who had been HIV infected before pregnancy has started. And this is also true for advanced HIV infections, where women are in the advanced stages of HIV infections. Then, when there are other sexually transmitted diseases present, there's also the HIV virus is also more infectious, if I can call it like that, because there are abrasions of the vaginal and cervical epithelium in the case of sexually transmitted diseases, which make entry of the HIV virus then so much easier in this case. Patients on ARV treatment are less infectious, and this also helps with a decrease of the viruses as it is. Now, there are a certain number of factors that can increase the risk of HIV transmission, and we have talked about them to a certain extent on the previous slide, but it is where there's a very high viral load of HIV viruses. We determine the seriousness of the HIV disease to a very large extent by determining the viral load, determining literally how many viruses are there present in the body. We have said that these viruses attack the CD4 cells to a very large extent, and that makes that the CD4 cells are not being effective anymore, and that makes a low CD4 count. So the lower the CD4 count, it actually shows us to what extent the body is already being affected. Other HIV-related illnesses, for example, the opportunistic infections, which we will come to later, and amongst them tuberculosis, sexually transmitted diseases we have just spoken on the previous slide with, and we have also talked about the repeated exposure, which makes the risk much higher and which makes the viral load also much higher. And we have also said that newly acquired HIV or women with newly acquired HIV infections are much more contagious. And these specifically, if they have acquired the HIV infection during pregnancy or during breastfeeding, makes the risk for passing the virus to the fetus much higher, because the viral load will obviously be much higher in these cases. Now, if we look at mother-to-child transmission in general, the HIV virus can be transmitted from an HIV-positive woman to a child during pregnancy, childbirth, and breastfeeding. Now, this happens more often or more readily during childbirth and breastfeeding than in pregnancy. It does not, and we will come to pregnancy and the transmission a little bit more in general during pregnancy. In pregnancy, usually the fetus is in his sac of membranes and his liquor, and is being protected to a large extent by the placenta and by antibodies that's been formed by the mother. Except if, as we've said previously, all the factors that might increase the transmission of the virus, like for example in repeated exposure, newly infectious, the very high viral loads, etc. And the same in childbirth and breastfeeding as well. Now, we're saying here that mother-to-child transmission is also, which is also known as vertical transmission, which we have said previously, accounts for the vast majority of infections, HIV infections in children. So the likelihood that if a child is HIV positive, that he has got it, the HIV virus from his mother, is very big. Now, without treatment, if a pregnant woman is living with HIV, the likelihood that the virus will be passed from the mother to the child is 15 to 45%. If the mother is on antiretroviral treatment, it can reduce the risk to below 5%. And we will come to this many more times during this lesson as well. Now, how do we diagnose HIV viruses specifically during pregnancy? I think the principles of diagnosis are fairly general, but if we specifically talk about childbirth here or pregnancy, usually when we are diagnosing any the presence of a virus in the body, we usually identify and see whether there are antibodies, because antibodies are usually produced by the immune system in reaction to this invading organism or this invading virus. So if we look at whether there will be certain, obviously if the mother is infected with HIV, the HIV virus, then she will produce antibodies against it. So if we look at the presence or look for the presence of HIV antibodies in an adult or a child older than 18 months, it indicates HIV infection. So what we do usually is, we do a combination of rapid tests and laboratory tests. There are rapid tests where we get test the mother's blood for HIV, presence of HIV antibodies, and we get the results rapidly, and that's why we call it the rapid test. And that's very convenient, specifically during pregnancy, that we can have immediate results whether the mother is possibly HIV positive or not. And then a laboratory test's been done. And usually, if both these tests are positive, we can make a definite diagnosis of HIV infection. But two tests have to be positive before we can say that the mother is HIV positive. And then I think what's very important for us to remember during pregnancy is that from the time of the infection till the test is positive, till the mother has now produced antibodies to make the test positive, can take 14 to 21 days, the so-called window period. And that's why it's very important for us to repeat the HIV test several times during pregnancy, so that we not only do it in the beginning when the mother is coming to the antenatal clinic for the first time, and then we don't do it again. Now, we also have to do some other tests or rely on some other tests which are not only relying on the HIV antibodies, and we call that a so-called polymerase chain reaction tests, or the PCR tests, where the DNA from the HIV can be detected. I think we've learned a lot about this during the COVID period, where we could detect the DNA from the COVID virus and have done PCR tests to diagnose COVID. Now, the same here with HIV infection. Where we use the PCR tests the most often is usually in the case of infants. Because when an infant is being born, he sits with a lot of antibodies that he got from his mother during pregnancy. So if we do the normal antibody tests on the infant, he will test positive. So that's the reason why we can't use the normal antibody tests on infants. We have to use the PCR test to make sure that that we're not testing the antibodies, but that we're testing whether there's a real HIV, whether he's really HIV infected. So if the PCR test is positive, give us a positive result, it means that the infant is positive. Now, what we usually do, the infant sits with a lot of antibodies from his mother for up to 18 months after his birth, and will give a positive antibody test for that period after the birth. So the PCR test is usually being done in around 6 weeks after the delivery of the baby, if the baby is not being breastfed. Because if the baby has been breastfed, there's also I almost want to call it a contamination of the blood by antibodies. So in the case of where the baby is not being breastfed and the PCR is being done 6 weeks after delivery and it's negative, then he's not being infected. If it's positive, it indicates that the baby has been infected with HIV, with the HIV virus. Then just briefly, the South African guidelines for testing. Now, if you want to know lots more about the testing for HIV and PMTCT and how mothers should be treated at clinics and when should what be done, you can look for the guidelines, the PMTC guidelines, and you will get all the information on that. As I've said, these slides and these lessons are basically based on all the important principles that's important for us during pregnancy to remember. Now, before a mother has been tested, it always goes hand in hand with counseling, and counseling and testing go together, and we call it the HCT, HIV counseling and testing. So, and we usually have a pre-test and a post-test. So during the pre-test, the mother has been taught everything about the test. Why should she be tested? What are the advantages of being tested? The possibility of HIV, the transmission to her baby if she's not been tested. So all mothers who are pregnant should preferably be tested if they are having an unknown HIV status. If they are a known HIV positive case, then obviously it's not necessary to test them again. or for those ones who have tested negative 3 or more months previously. Because as we've said previously, with the transmission of HIV, mothers can get infected at any time, and newly been infected at any time. So this HET should be offered at the first antenatal visit. The mother should be counseled and then tested, and then they should been given all the information about the PMTCT program, as I've said, all the implications for them to be tested, and then they must give consent to be tested. If they don't give consent, if they refuse to be tested, then just a lot of emphasis should be given and information should be given to them about the effects and the possible effects on the baby if they are positive. And then post-test counseling is usually, if the mother is positive, about the implications of her being positive, treatment, breastfeeding, etc. Now, breastfeeding we will come to in the last lesson again too, but this should be done right through pregnancy and shouldn't be waited till the baby has been born and then give the mothers information on what they should do or whether they should not breastfeed. Mothers should also be counseled when they are HIV negative, because as I've said just previously, the mother can get HIV positive at any stage. So mothers should know, and we will come to that again later on, should have a lot of information about the use of condoms, the prevention of becoming infected, etc. And then, as I've said also, HIV testing should be repeatedly offered to HIV negative women during pregnancy to make sure that they stay HIV negative during the whole of pregnancy. And that brings us then to the end of lesson 1. So please complete your quiz and then you can continue to lesson 2.